Oncologist, Clinical Director, KIMS Hospital, Hyderabad. Also, sir practices in Renova Cancer Center. So, sir is having 15 plus years of experience. Sir, over to you, sir.
Yeah. Thank you so much, Sandeep, and a very warm welcome to everyone for today's webinar on prostate cancer, where we intend to discuss about how uh, we can reach new heights in the care of metastatic hormone-sensitive prostate cancer, and also how to expand the horizons in the metastatic HSPCT setting without chemotherapy and with chemotherapy. So, evidence from two key trials will be discussed today. Essentially, we'll understand the treatment landscape of metastatic hormone sensitive prostate cancer. We'll discuss the clinical updates in the management of metastatic HSPC, and by so doing, we'll gain insights on the evolving scientific narrative for darolutamide doublets and triplets in metastatic HSPC, and essentially the implications of clinical practice in India. So, joining me are two eminent speakers, Dr. Arun from Trivandrum and Rajiv Gandhi from Vellore. Dr. Arun is a consultant medical oncologist from KIMS Health Cancer Center in Trivandrum. He will discuss over the coming 20 minutes about reaching new heights in metastatic hormone sensitive prostate cancer care. Dr. Arun, a warm welcome for today's session, and I now hand over the podium to you to take us forward about reaching new heights in the care of metastatic hormone sensitive prostate cancer. Thank you so much, Arun.
Good evening.
Good evening.
Good evening. Is it possible to share the screen? Like I'm not able to do that. Can you just show me this? Is it possible to share the slides?
Sandeep, could you please help?
Yeah, give me a minute, sir. I'm
Yeah,
just
sure. Yeah.
Sir, after sharing this slides, I will not be able to speak. So, you just tell me, sir, next slide. So, I can
Yeah.
move the slides, sir.
Yeah, sure.
Thank you, sir.
Okay. So good evening. And I thank the organizers for opportunity. So we know that prostate cancer is one of the most common cancers in the men worldwide, and they often present with either de novo metastasis or they later develop metastasis after prior local therapy. Metastatic HSPC, it is not a uniform entity. There can be high risk group, low risk group, high volume group, low volume group, etc. So the key role is delaying the progression of metastatic HSPC to developing CRPC, because ultimately all the patients with metastatic HSPC becomes CRPC, and ultimately it results in death. So our aim is delaying CRPC. Next slide. Next slide, please. So delaying development of CRPC can improve the outcome. So this is actually the stampede control group. That is, this is the control arm of the stampede group. And we can see that the green arm, the green curve shows the failure-free survival and orange one shows the overall survival. We can see that the failure-free survival drops very early. That is, the disease progresses rapidly while the patient is on ADT alone. And the OS decline is very slow. That is, the patient can live longer despite progression because of the good subsequent lines of therapy. With ADT alone, we can see that the median FFS is only 11 months, while the median OS is 42 months. So there is a big gap between the green and the orange. It is the time where we used to wait, but now we have to intervene early. This curve laid the foundation for upfront treatment identification strategies. Next slide. So this is the stampede analysis of RT to the primary in metastatic HSPC with outcomes stratified by disease burden. That is, if it is less than 4 skeletal sites or more than 4 skeletal sites. And the comparison is made between the standard of care and standard of care plus RT. Standard of care can be ADT with or without systemic therapies. So we can see that in the graph, for low volume metastatic HSPC, the FFS clearly separate with a hazard ratio of 0.056. That is, there is almost 44% reduction in the delay in FFS. And OS, the curves separate meaningfully with a hazard ratio of 0.64. That is, there is 36% reduction in the death. But in high volume HSPC, we can see that the two curves are clinging. That is, in FFS, the hazard ratio is only 0.86 and OS is like 1.11. That means there is no significant difference. So in low burden disease, the primary tumor itself is the source of metastatic CD, while in high burden disease, it has already disseminated and local control adds nothing, or there is only minimal impact of on the survival with a better local control. So in low volume metastatic HSPC, we can add RT to the systemic therapy, while for high volume, there is no benefit with addition of RT. Next slide. So there has been various studies, there has been various trials which incorporate addition of further chemotherapeutic agents or other ARPIs. We can see that there are trials evaluated the addition of docetaxel, enzalutamide, apalutamide, then darolutamide, then adding triplet therapy, etc. So all these have evolved over the past 10, 15 years and which has resulted in a better outcome in patients with metastatic HSPC. Next slide. So this is the charter trial of docetaxel in metastatic HSPC. We can see that in high volume metastatic disease, that is, those with visceral metastasis or those with more than or equal to 4 bone lesion with at least one outside the vertebropelvis, we can see that the median OS with dosi with ADT is like 51.2 months, while with ADT alone, it is 34.4 months. So the hazard ratio is 0.63. That is 37% reduction in the death with a significant p-value. And the absolute OS benefit is 16.8 months. But for low volume disease, the hazard ratio is only 1. P-value is 0.86, which is not significant. Next. In Latitude trial, it is adding abiraterone and steroid prednisolone to ADT versus ADT alone. The study population was newly diagnosed metastatic HSPC with high-risk disease. High-risk means patients should have at least 2 or more of the high-risk features. That is, Gleason score more than or equal to 8, more than or equal to 3 bone metastasis, or presence of visceral metastasis. And we can see that in the left side OS curve, we can see that the median OS with ADT with abiraterone is 53.3 months, and with ADT alone, it is 36.5 months. The hazard ratio is 0.66. That is 34% reduction in the death for high-risk metastatic HSPC. And the secondary endpoints studied were radiographic PFS. We can see that the hazard ratio is around 0.47. Then it also assessed the other features like time to PSA progression, time to chemo initiation, time to pain progression, and time to the skeletal events. We can see that the hazard ratio is all favoring the use of abiraterone to ADT in high-risk group. So the basic takeaway point is like abiraterone plus ADT. It is a standard of care for high-risk metastatic HSPC. We can also try docetaxel as an alternative. And earlier treatment intensification with ADT with abiraterone improves the OS and disease control in high-risk metastatic HSPC. Next slide. So this slide actually answers some of the common clinical concerns, like the safety of abiraterone. Is abiraterone safe in metastatic HSPC with a low dose of prednisone, that is 5 milligram OD? So we can see that the common key toxicities which we could see were hypertension, which was seen in around 22% with abiraterone. That means it was grade 3. And grade 4 hypertension was seen in 1%. With the ADT alone, it is only 10%. We know that it is just because of the mineralocorticoid excess due to abiraterone. And liver toxicity is also mildly elevated, which is manageable, but hypokalemia incidence is like 11 versus 1%. The cardiac toxicity is like 3 versus 1%. Edema is comparable. The level of osteoporosis is also the same. And the incidence of cataract is also less than 5% with this long-term steroids. Even with 5 mg prednisolone, abiraterone shows predictable mineralocorticoid toxicities like hypertension and hyperkalemia, but safe and manageable only. Next slide. This is a slide of Titan trial where apalutamide was compared to apalutamide plus ADT was compared to ADT alone. And we can see that the PFS was showing a hazard ratio of 0.48, that is 58%, 52% reduction in the progression. OS, the hazard ratio is 0.65. In the subgroup analysis, we could see that low volume disease had a 64% reduction in the risk of disease progression, and high volume had 47% reduction in the risk of disease progression. So the takeaway point is like ADT with abiraterone works both in, with apalutamide works both in low and high volume disease, and it can work both in de novo as well as recurrent metastatic HSPC, and the greatest benefit is for the low volume disease. Next slide. This is the ENZAMET study, where almost 1,125 patients with metastatic HSPC were stratified to enzalutamide plus ADT versus ADT alone. And the clinical PFS, the hazard ratio was 0.4, and for OS, the hazard ratio was 0.67. Major OS benefit was seen in low volume disease with a hazard ratio of 0.43, and only a borderline benefit was seen in high volume disease, that is hazard ratio of 0.8. So in high volume disease, a further treatment intensification is needed. Next slide. So far we dealt about the dual therapies. Now it is adding a third agent, that's a triplet therapy. That is, one is PEACE-1 study. We can see that almost 1,173 patients with metastatic HSPC, that is de novo, they were included in this study. They excluded those who already received chemotherapy and those who had a recurrent HSPC. And patients were stratified based on disease volume, the performance status, the type of ADT. And it was a 1:1:1:1 factorial design. The arm A was a standard of care. It started like ADT, but later it was amended to include ADT with docetaxel. Arm B was standard of care plus abiraterone and steroid. Arm C was standard of care plus RT. And Arm D was standard of care, abiraterone, steroid, and RT. So this factorial study helped us to know the help us to assess the interventions simultaneously. That is, what is the effect of abiraterone as well as what is the effect of RT. And it is the first trial that evaluated triple therapy, showing benefit of ADT plus docetaxel plus abiraterone in high volume disease. Next slide. So the two Kaplan-Meier curves are seen. On the left, you have the curve of high volume disease, and the right, it is a low volume disease. And it compared ADT dosi versus ADT dosi and abiraterone. We can see that there's a good separation of curve for the high volume disease, that is improved PFS and OS. In low volume disease, the curves are closer, and there is less pronounced OS benefit, which is not statistically significant. So the takeaway point is like adding abiraterone to ADT plus dosi is beneficial in high volume disease, not in low volume disease. So if high volume disease, you can think about triplet therapy, and for low volume disease, you can go with the standard of care. Next slide. This is the Arasen study group, where almost 1,300 patients with metastatic HSPC with good performance status were randomized to either darolutamide, ADT docetaxel, or ADT with docetaxel alone. And the patients were stratified based on the disease volume, whether it is M1A, M1B, or M1C, or based on the level of alkaline phosphatase, whether it is less than or more than the upper limit of normal. The endpoint was overall survival, the primary endpoint. The secondary endpoints were time to CRPC, time to progression, time to skeletal events, time to subsequent therapy, time to PSA progression, time to opioid use, and the safety. And we could see that almost 87% of the patients completed the planned 6 courses of docetaxel. Next slide. Next slide, please. Yes. So for the overall population, we can see that the hazard ratio is 0.68. That is, there is 32% reduction in the death. The median OIS is not reached in the darolutamide arm. The control had a median OIS of 48.9 months, and the four-year overall survival was like 63 versus 50%. In the high-risk group, the hazard ratio was 0.71, and for low-risk group, it was 0.62. So we can see that the takeaway point is like triple therapy is superior. There is consistent OS benefit across all the subgroups. The magnitude of benefit is very strong, and there is no compromise in the delivery of docetaxel also. Next slide. And coming to the secondary endpoints, we could see that there was significant improvement in the time to CRPC. The hazard ratio is 0.36. That is, patient takes longer time to develop CRPC. Time to next antineoplastic treatment hazard ratio is 0.39. That is 61% reduction, which shows prolonged benefit of the first-line therapy. The time to progression hazard ratio is 0.79. It is modest but significant. It gives a better symptom control and a better quality of life. Time to first skeletal-related event, it is 0.71. That is, there is delay in fracture as well as spinal cord compression. Overall, the triplet therapy showed deep disease control. It had delayed the next line therapy. It improved the symptom, improved the quality of life with reduced skeletal complications. Next slide. This is the slide that actually shows the PSA response and the outcome. So undetectable PSA or deep PSA response is, it is actually a PSA value less than 0.2. We can see that with a triplet therapy at 24 weeks, almost 48% of the patients had a deep PSA response, while it was only 24% in the ADT dosiam alone. At 36, 52 weeks, we can see that the percentage getting deep PSA response is significantly higher compared to that of the standard of care. That is, there is almost doubling of deep PSA response. So patients getting a deep PSA response have a 77% reduction in the PSA progression. And PSA at 36 weeks is highly prognostic. On the right side, we can see the overall survival curve, the right Kaplan-Meier curve. The undetectable PSA, for patients with undetectable PSA at 36 weeks, median OIS is not reached. Those with the detectable PSA, the median OIS is 33.5 months. The hazard ratio is 0.37, that is 63% reduction in the death. An early PSA response will ultimately translate to an OS advantage. Next slide. So we can see that almost 2 out of 3 patients get undetectable PSA at 36 weeks. PSA at less than 0.2 at 36 weeks is a predictor of overall survival, and this PSA kinetics can be used as a surrogate marker. Next slide. So in high volume metastatic disease, we can see that the PSA kinetics and survival outcome is, the slide actually shows the PSA kinetics and the survival outcome in high volume disease. We can see that undetectable PSA was seen in 25% of the high risk group, high volume disease, versus 14% in the standard of care. Again, we can see that the time to PSA progression, we can see almost 80% reduction with darolutamide. And overall survival, we can see that 70% reduction in the death was seen. That is, deeper PSA response in high volume metastatic HSPC with triplet therapy translated to an overall survival advantage in high volume disease. Next slide. This slide actually shows the PSA kinetics for low volume disease. Here also we can see there is almost doubling in the rate of PSA deep response, and time to PSA progression, we can see there is almost 91% reduction with 66% reduction in improvement in the overall survival. That is, there is improved depth of response, there is delay in the CRPC, and a better OS. Next slide. So it is always better. You can choose a triplet therapy when we feel the disease is aggressive, if the patient is able to tolerate docetaxel, when it is a high volume disease, when there is a great likelihood of hormone insensitive clone, when the patient is young, and you expect a longer life expectancy. So the increasing trend, next slide, please. So we aim to use docetaxel very early. The later use of the later part of the hormone sensitive phase using docetaxel, it will be less effective. Also, patient may not be fit also to receive docetaxel. So early docetaxel can actually reduce the development of ADT resistance. So, but the patient has to be informed about the logistics, the OS advantage, the toxicity, as well as the added toxicity of chemotherapy. Thank you.
Thank you so much, Arun. That was very well discussed by you, and the elaboration was excellent. I think all of us learned a lot about the Arasens trial, and I think it's very clear now that adding darolutamide to ADT and docetaxel significantly improves the OS and metastatic HSPC. After listening to your talk, it further gets reiterated, and therefore it is an established standard of care. Having said that, I just thought I'll just try to give some key points. Essentially, the study compared Daro ADT docetaxel against ADT and docetaxel. It did not compare this triplet against the most commonly used doublet therapies in clinical practice, like say ADT plus abiraterone, enzalutamide, or apalutamide. So that becomes one limitation as lack of direct comparison to other modern treatments. As rightly pointed by you, there's a high proportion of synchronous disease. 86% of patient trial actually had synchronous de novo metastatic HSPC. So you can't really generalize the findings to men who have metachronous recurrent metastatic hormone sensitive prostate cancer. The trial showed benefits, specific subgroup analysis, especially the non-regional lymph node involvement. There, the benefit seems to be limited, non-significant, or weaker when compared to patients with visceral or bone metastasis. Some ethnic groups were underrepresented. Low enrollment of Black patients. We had more than 1,300 total patients, which actually is a very good number and therefore an extremely well conducted trial. 54 were only Black patients. So now, as we know, that there seems to be worse outcomes in prostate cancer. Therefore, the limited evidence for this demographic because there's underrepresentation of these ethnic groups. Some age related findings were based on post hoc rather than pre-planned primary endpoints. The regimen includes docetaxel and darolutamide. Now, this triplet of docetaxel, daro, ADT may not be suitable for frail patients or those with severe comorbid conditions. So, on one hand, age less than 75 years or more than 75 years, no issue at all. But that's a physiological age. It's important to look at the fact that if a patient is frail or has severe comorbid conditions, we possibly would not want to give docetaxel. So I think these are some of the key limitations. Otherwise, overall, to summarize, lack of direct comparison to other modern treatments, high proportion of synchronous disease, limited data on some specific subgroups like those with M1A disease, non-regional lymph node involvement, some ethnic groups like the Blacks, highly underrepresented, some age-related findings. It was more a retrospective or post-hoc data collection, and high treatment burden. But if the patient is frail or severe comorbid conditions, then probably you would not want to use docetaxel. But having said that, I think this trial is robust design, large number of patients, has expanded the option for managing metastatic hormone sensitive prostate cancer, particularly showing benefits regardless of the patient's age. So that becomes the key selling point. Therefore, we are also comfortable using this regimen in medical oncology practice. So with that, now let's come to the second talk for today. But I'm so happy, Arun, you really brought out the entire way how new heights are being reached in the management of metastatic hormone sensitive prostate cancer. With that, we will now invite Dr. Rajiv Gandhi. Sir, are you there?
Yes, sir. I'm here, sir. Good
Yeah,
evening, sir.
yeah. Thank you.
Good
Good
evening.
evening, dear. Good evening. So, Rajiv Gandhi is consultant medical oncologist from the Sri Narayani Hospital and Research Center in Vellore. He would talk us over the coming 20-30 minutes, he'll talk to us on advancing MS-based metastatic HSPC treatment horizons. Darolutamide without chemotherapy, the aeronaut evidence, because as I just discussed, that in patients, regardless of the age, if they're frail, they're fragile, have a borderline ECOG performance or some comorbid conditions, then you might not want to use docetaxel. What do we do then? Rajiv, over to you, the aeronaut evidence.
Thank you, sir. Thank you for briefing the need for Arano trial in CSPC patients. And thank you, Arun, sir, for like he already set the platform for the management of metastatic CSPC patients. And I'm going to talk about the Arano trial, which is almost like a de-intensified version of Arasen's trial. Thank you, Bayer, for giving me this opportunity. And for the technical team, if anybody is willing to share the slides, it will be great for me to start the discussion. Anybody there from the technical team?
Yeah, 1 minute, sir. I'm sharing the slides.
Yes.
Give me a minute, sir. Sir, I will be on mute. Just please continue the session, sir, once you see the slides.
Sure. Yeah.
Give me a minute, sir. I'm sharing.
Yeah. I'll continue my discussion for the day. And again, thank you, Bayer, for giving me this opportunity to discuss about metastatic CSPC. And as we know, like the management of metastatic hormone-sensitive prostate cancer is evolving day by day. And the role of darolutamide without chemotherapy is my today's topic. Because most of the patients we see in our daily clinics are advanced age patient with multiple comorbidities, and almost 90% of the patients in my clinic, like I'm unable to give triplet therapy because of the comorbidity and the advanced stage of the patients with multiple polypharmacotherapy patients, those multiple interactions can happen. So in those patients, we prefer to go ahead with ADT with any one of the androgen receptor pathway inhibitor. And down the line, we'll see how we are going to put darolutamide plus ADT in that place. And this is the treatment evolution of metastatic hormone-sensitive prostate cancer. Initially, one ADT was the only option we had. Now, slowly, docetaxel was combined with ADT. And down the line, we have multiple oral therapy options like androgen receptor pathway inhibitors and androgen receptor inhibitors, abiraterone, enzalutamide, apalutamide. Everything worked out for these patients, and we tried to intensify the patient to get maximum response for those metastatic patients, and they keep them under treatment without disease progression and without making them progress to castration-resistant prostate cancer. Slowly, we are in the time of darolutamide ADT plus docetaxel triplet therapy, and along with addition of radiation therapy as based upon PEACE one trial, as Arun sir was discussed. And now my topic is on de-intensification area, where minimizing the treatment and getting maximum efficacy out of the less toxic treatment. And down the line, we'll see how this protocol, this darolutamide with ADT combination is going to work for this patient. Though there is very good evolution in management of prostate cancer, most of the patients, HSPC patients, progress to castration-resistant prostate cancer within 3 years. There is one issue. This is the main issue in management of HSPC. The unmet need for these patients is because though we have multiple treatment options, most of the treatment options are coming with added toxicity. So we are trying to give better treatment, but patients are suffering from toxicity of the treatment. So this Arano trial, global phase 3 trial, is designed to address this important issue. And as we know, most of our metastatic prostate patients are advanced age and they can't take cytotoxic chemotherapy. So bringing the minimal treatment with getting maximum response out of it is the prime area to explore. So next slide, please. Yeah, daratumumab plus ADT plus docetaxel is a standard, as I was telling initially, based upon the Arasen's trial, what Dr. Arun sir was discussing previously. This Arano trial is nothing but the de-intensified version, where we are dropping the chemotherapy part in that treatment protocol, and we are going to see how this is going to be beneficial for the patients. Next slide, please. This is the study design ARA-NOTE, which is a randomized double-blind placebo-controlled phase 3 trial. And the patients were metastatic HSPC, histologically proven cases, and ECOG performance status of 0 to 2. And the patient was stratified based upon visceral metastasis, and prior local therapy, anything was taken off. And they were randomized with the ratio of 2:1 in their trial and on the placebo arm. And the primary endpoint is radiological progression-free survival is the primary endpoints, and the multiple secondary endpoints like overall survival, time to initiation of subsequent anti-cancer therapy, time to CRPC progression, and time to PSA progression, and rate of undetectable PSA level, which is less than 0.2 nanogram per ml, and the time to pain progression, and safety, and other pre-specified endpoints were PFS on the second analysis, and time to significant skeletal events, skeletal-related events, and the time to deterioration of functional assessment in chemotherapy in prostate patients, and time to first prostate cancer-related invasive procedure. These were the pre-specified endpoints, and selected endpoints for overall survival and safety. Next slide, please. These were the patient characteristic at the baseline. Almost patient were in the both trial and the standard arm patient were in the ratio of 2:1, 446 patient in the trial and 223 patient in the placebo arm. And we got good number of Asian patients. In that, Indian patients were also included. We'll see the number of Indian patients in that in the study. And next thing, what interesting to note is where there is very good number of high volume disease patients. Almost 70% of the patients were high volume in both arms. And median PSA level was 21 in both the groups. And visceral metastases were 11%, 12% in the trial and placebo arm respectively. And the prior local therapy was taken on 17% in approximately 17% in both trial and the placebo. Next slide, please. Country representation along the trial, we can see Asian inclusion in the Arano trial. We have like majority of the patients are, I think, Asian. 30% of the patients are from Asia, and we can see Indian patients are 13% in trial arm and 14% in the placebo arm. Like this is a multi-center trial, so considering it, 13% of the patients from India is a very good number, what I assume. Next slide, please. This is the primary endpoint of the trial, which is radiological progression-free survival. When we compare this Kaplan-Meier curve, when we compare the trial arm at the time of 24 months, almost 70% of the patient were there is no radiological progression-free survival, and 52% of the patients were in radiological progression-free survival. So hazard ratio is 0.54, which tells that almost 46% of the patient, 46% reduction in radiological progression or death in trial arm comparing with in study arm comparing with the trial arm. Next slide, please. This is a subgroup analysis in which multiple subgroups were analyzed. In the forest plot, you can clearly see every subgroup is in left of the line of unity. So, which tells that the use of this darolutamide and ADT is a broad spectrum, which can be used in every different subgroup of patients, irrespective of volume of the disease, phase of the patient, geographical location, and the visceral metastasis status, and the PSA level. So it is not confined to any small subgroup. So every subgroup patients are getting benefited. This is clearly seen in the forest plot. Next slide, please. Yes, this is the overall secondary endpoints, where overall survival is also on the left of line of unity, and time to progression to CRPC and the PSA progression. Everything is in favor of darolutamide arm. Since the OS is immature, patients will be followed for the overall survival, but the trend is in favor of darolutamide plus ADT only. Next slide, please. Yeah, this is the other after the OS. This is time to progression of CRPC, in which darolutamide arm the hazard ratio is 0.4. And the time to pain progression hazard ratio is 0.72. Delay in time to pain progression can be a significant thing. This is the day-to-day clinical symptom what we are encountering. So pain progression delay is what matter than for the patient. So next slide, please. This is PSA level attaining the undetectable level. In darolutamide arm, 63% of the patient, overall population, 63% of the patient attained undetectable PSA level, comparing with only 18% of the patient in the placebo arm. And the time to PSA progression is also significant, with the hazard ratio is 0.3, which is statistically very significant, comparing with the placebo arm. And 63% of the patient in the darolutamide doublet attained undetectable PSA level, and this represented the 69% improvement in the PSA progression in trial arm. Next slide, please. This is during the treatment period, almost within almost like 6 weeks, 24 at the 24th week, almost 44% of the patient attained undetectable PSA level, and it continues to increase from 44, 47, 50, and 54, comparing with maximum of 15% in the trial arm. In high volume disease, whereas in the low volume disease, we can see it's it is not completely incomparable with the placebo arm. So patients are almost 82% of the at any time in this, at 82% of the low volume disease patient attain the undetectable level of PSA, comparing with only 25% of placebo group. Next slide, please. Patient with subsequent therapy. As we know, we are treating the metastatic patient. So at some point of the time, patient may progress. So patient fitness to tolerate further anti-cancer therapy is the one important thing we have to consider. So almost patient with subsequent therapy were 32% and 42% in placebo arm. Patients were fit to receive docetaxel in 22% and in darolutamide arm, and 28% in the placebo arm. So which shows that those patients who are progressing are still fit and capable to continue further anti-cancer therapy. So this is one important thing we have to consider before choosing any cancer therapy. Next slide, please. Incidence of treatment related adverse effect. Though we are treating the patient with darolutamide and ADT, and treatment related discontinuation and treatment tolerance are in favor of darolutamide. When we compare the grade 3 side effect, it is 30 in both darolutamide and placebo arm, and any adverse event is 91/90, which is like patients are not experiencing any side effects due to the treatment and due to the treatment of darolutamide plus ADT, comparing placebo plus ADT. And treatment discontinuation is 6.1. In fact, it is less comparing with placebo, where it's 9. So it's not only about treating the patient with a lesser toxic regimen is the one we have to take consideration in this from this trial. Next slide, please. The most common adverse effect, as we know, adverse effect is inevitable in long-term treatment, and we are trying to minimize as much as possible with available treatment option and other androgen receptor inhibitor like enzalutamide. We can encounter multiple central nervous system related side effects, asthenia, and drug interaction. There's a multiple restrictions in using those androgen receptor inhibitors, whereas in darolutamide, where it scores much better than their competitors, and nothing special, nothing new adverse effect between darolutamide and placebo arm. So this is one good drug we can easily prescribe to the patient in daily clinic. Next slide, please. As I was discussing earlier, the cardiovascular related side effect and CNS side effects are almost similar between the study arm and the trial and the placebo arm. So we are not supposed to worry much before prescribing darolutamide in those patients with prior cardiac comorbidities. So this is one valid point we can consider before prescribing darolutamide plus ADT in frail patients or patients more than 70-year-old. Those are unfit. Those are seems to be unfit for docetaxel. Next slide, please. Yeah, this is health-related quality of the life. The darolutamide extended median time to deterioration of like functional assessment cancer therapy in prostate score by 5.1 months versus placebo. So patients, that fact score is nothing, but they are taking multiple aspects into consideration during treatment, like social aspect, emotional aspect, functional aspect, and patients' daily disease-related symptom aspect. The multiple things were taken into consideration. So darolutamide plus ADT works much better when FACT score is taken into consideration. The delay in pain progression is the overall well-being. Everything is in favor of darolutamide comparing with the placebo plus ADT. Next slide, please. Yes, darolutamide doublet delays the deterioration of the well-being. As I was telling, social, functional, urinary related symptoms are in favor of darolutamide as in this forest plot. So as I was discussing in the previous slide, it is not only the lab-oriented and radiological benefit is there. Functional benefit and social benefit, day-to-day patient outcomes are much better in tolerability, and everything is in favor of darolutamide comparing with the placebo. Next slide, please. Here we are in the conclusion, last few slides of my presentation. Darolutamide and ADT significantly improved radiological progression-free survival, which is the primary endpoint of ARANO trial. And the benefit is seen across all secondary endpoints also, like overall survival, time to progression to CRPC, time to pain progression, and undetectable PSA level. Everything is in favor of darolutamide. And a deeper PSA level of undetectable PSA level is attained irrespective of the baseline PSA. And darolutamide is the first and only AR inhibitor which meaningfully delays pain progression, overall well-being, and urinary symptoms, everything. And darolutamide has a favorable safety profile without any new cautions to take during treatment. Yes, What I want to mention is like dialytomy ADT is one valid option we have in frail patient, as Sir was telling before the start of the presentation. What we are going to do for frail patients who are unfit for docetaxel, here we have some answer from Aaron Wood, sir. So next slide, please. Over to you, sir. Thanks for giving me this opportunity.
Thank you so much, Rajiv. Excellent presentation. You brought out all the points relevant for the Arrow note, and then with Arun setting the context and giving us a fair idea about the ideal patient for triplet. You also discussed about the ideal patient for the doublet. So the Arrow note showed significant efficacy for Daro plus ADT and MHSPC. One criticism has been the outdated control arm, as some of the critics call the ADT alone, which is presently not a current standard of care. Now, in that regard, the some limitations become critics arguing that comparing Daro ADT to ADT alone is an inferior control group because most patients in many regions would receive either doublet or triplet as standard of care, not ADT alone. Now, the trial also did not compare Daro against other commonly used ARPIs in the MHPC setting, relying on network meta-analysis for contextualization because they looked at network meta-analysis and the drug coming in context. Now, Dr. Fred Saad, I actually read one of his recent commentary, and he was trying to give an idea about why the choice of the studies control group was ADT alone, because evidence from real world studies at the time of the Arrow note, which is from March 2021 to August 2022, that was when the trial was enrolling or was active, many patients were still getting ADT alone for various reasons like access, tolerance, and drug-drug interactions. The trial was in Canada, South America, Europe, Asia, and Oceania. Many of the patients did not have access to more than ADT, or they were not eligible to receive available therapies for metastatic HSPC in their respective centers and countries. ADT at that time when the trial was getting started or initially acceptable and commonly used standard of care in the enrolling countries, and therefore ADT was an acceptable control arm for these patients. So, if you look at all the statistics, there are a lot of patients who receive ADT alone, and that's what Dr. Fred Saad explained in the interview. When the study was being designed, ARPIs were not routinely reimbursed in Canada, and Australia, it was a very recent approval of ARPIs in metastatic hormone sensitive prostate cancer. And so the trial design of ARANOTE was pragmatic. It reflected actual clinical practice. More importantly, the 2:1 randomization ratio of the ARANOTE means two-thirds of the population had access to an intensified treatment with Daro plus ADT, which they would have been unable to access otherwise. The trial criteria were flexible enough to allow inclusion of a broad metastatic HSPC population. And so, the fact or the premise that the control arm is outdated probably is not appropriate if you look at the trial time because it was between March 2021 and August 2022. Now, thirdly, while radiological PFS is robust, but assessing OS, as we all know, is complex due to subsequent therapy options. The trial confirmed the benefit of adding Daro to ADT without docetaxel, but the relative benefit compared to or in combination triplets remains a subject of ongoing analysis. The study population was a reflective of clinical practice, but the stringent criteria of eligibility in the trial can differ from real world, real time clinical practice, specifically with regard to the performance status. So, these were some of the limitations, but the study published in detailed analysis Like that you see in Science Direct shows that Daro plus ADT has a strong safety profile when compared to other doublet combinations. And that becomes the most important selling point because to our patients of metastatic hormone sensitive prostate cancer, we want maximal efficacy against the disease and to the patient minimal toxicity. So, with that, since we are now close to 50 minutes and with such elaborate discussions by Arun and Rajiv on the ARASENS and ARAN respectively, let me now go ahead with my real world case selection of one of my patients who received darolutamide. So, this was a patient, just one second. So, this was a patient who came with a PSA of 30.61, the age was 64 years, no comorbid conditions, Indian ethnicity, and next, he was de novo high volume metastatic hormone sensitive prostate cancer based on the PSMA PET CT findings. Next slide, please. The raised PSA more than 30 and the biopsy findings showing a Gleason 4 plus 4 acinar adenocarcinoma of the prostate. In January 2023, the PSMA PET CT scan showed enlarged prostate, left lobe hypertrophy, indenting the base of the bladder, regional nodes involved, and extensive skeletal metastasis. So the patient underwent TURP, was explained about orchidectomy in January 2023, but chose not to undergo surgical orchidectomy. After that, the patient was started on leuprolide, the LHRH agonist, along with docetaxel. The plan was to give 6 cycles of docetaxel as per the protocol, but in between some dose reductions which happened substantially, therefore, the tumor board discussion and decision was that let's give 8 cycles to compensate for the dose reduction. So 8 cycles of docetaxel. The last was in August 2023. But initially, the patient was also counseled about an intensified treatment by using a triplet of ADT, the LHRH agonist, plus docetaxel, and to add darolutamide to it. Docetaxel started, ADT continued, but the patient needed some time for circumstances to start or add darolutamide. So in June 2023, midway when docetaxel was going on, as a triplet, now you had the addition of darolutamide also. The reason for choosing this triplet was in line with the data from the RSS trial. We all know the other option could be ADT plus abiraterone plus prednisolone, the PEACE-1 study, but elegantly, Rajiv has shown us the pros and cons of the triplet of the PEACE-1 trial. So, without going into those details, our patient chose maximal efficacy and minimal toxicity. Next slide. The PSA dropped from 30.61 to 0.08 in November 2023 and 0.01 in December 2023. As I told you, in Jan 2023, the first PSMA PET CT scan was performed. 9 months into treatment, a repeat PSMA PET scan showed improvement in all the metastatic sites as shown in this picture here. Next. So there were no PSMA expressing pelvic lymph nodes, resolution of the previously seen lesions involving the skeleton, significant reduction of PSMA expression, and next slide. On 20th of December 2025, the PSA became as low as 0.04. So my treatment experience, next slide, with Daro has been response to treatment with docetaxel ADT was very good. And then halfway through, after raising finances, the patient added darolutamide too. During chemotherapy, the patient had fatigue, joint aches, body pains, joint pains, hair loss, some amount of neutropenia, but essentially more of fatigue, asthenia, malaise. Since completing chemotherapy, these symptoms have resolved. Again, reiterating the fact that chemotherapy is the main reason for the adverse events and not darolutamide. The patient has been continuing Daro to date. My safety experience, next slide. Full dose Daro, very well tolerated. The patient comes for checkup every 3 months, next slide, which is physical examination and some routine blood works. The follow up is timed with the ADT so that the patient comes every 3 months to take the subcutaneous shot of the LHRH agonist, leuprolide acetate. So, in conclusion, next slide, I would have three conclusions. Arasense is effective, well tolerated, triplet benefiting high volume metastatic hormone sensitive prostate cancer patient, as shown in my real world case data. The benefit of Daro, apart from the efficacy, is the good safety and excellent tolerability profile. It also benefits patients who are on polypharmacy as well due to its limited drug-drug interaction profile. I would just want to briefly discuss on three questions. Next slide. Should triplet treatment, be limited only to high volume MHSPC patients or given to low volume patients too? Briefly, the answer is the ASCO, the ESMO, and the CSCU have global guidelines for high volume metastatic hormone sensitive prostate cancer, triplet of both the PEACE-1 study and the DARO triplet. For low volume metastatic HSPC, strong recommendation for the DARO triplet, and there's no recommendation for the abiraterone triplet. This was again pointed out by Rajiv. Now, this high volume or low volume metastatic hormone sensitive prostate cancer, the triplet of ADT plus Daro plus docetaxel, more than 30% reduction in the risk of death, which was consistent with the overall population. Next slide. Now, how do we choose between the triplet regimens? Should I choose the PEACE-1 or should I choose the Arasense? Now, with regard to the PEACE-1, we have higher severe grade 3 or more hypertension, higher grade 3 or more hepatotoxicity, and we know there could be a potential for drug-drug interactions because these patients are on a low dose steroids along with the abiraterone. And so I think the safety profile really makes us choose the triplet. Having said that, I think it becomes very clear that abiraterone requires frequent monitoring recommendations for mineralocorticoid excess, hepatotoxicity, and adrenocortical insufficiency. And lastly, next slide, should doublet treatment be considered in patients having high volume metastatic hormone sensitive prostate cancer? The guidelines recommend a treatment with the doublet of ADT plus an ARPI or a triplet of ADT, ARPI, and docetaxel. So these are grade category 1 recommendations. Now, since we don't have predictive biomarkers, randomized trials comparing triplet doublet also are not there. Selection of patients who can benefit more from either regimen still continues to be an area of active debate, but that debate I think was very well settled by Rajiv in his previous talk and by Arun as well. So multiple trials have looked at ADT, ARPI in treatments with MHSPC. In all these studies, a consistent improvement in the OS was observed with the doublet when compared to the control arm of ADT with a hazard ratio between 0.61 to 0.7, p-value less than 0.001. Next slide. With that, I come to the conclusion of my talk. It's 8 o'clock at 7 p.m. We started, 8 p.m. dot we ended. But more than that, excellent learning from my colleagues. And thank you, Bayer and Sandeep especially, for making it as a part of this academic interface across cities to discuss about darolutamide, might take maximal efficacy against the disease and to the patient minimal toxicity. That's what darolutamide satisfied, especially zero potential for drug-drug interaction. Thank you so much.
Thank you, sir. Sir, before closing, sir, let me check if any questions in the chat box. So, 1 minute, sir. Let me check. Yes, sir. I don't see any questions in the chat box. So my sincere thanks to Dr. Arun sir for presenting the presentation on RSS data. Also, Dr. Rajesh sir for presenting the data on Aeronaut. My sincere thanks to Dr. Dattatreya sir for presenting the case. So I think, sir, with this we can conclude the session. Thank you so much, sir. Thank you for all the doctors for joining today's discussion. Thank you.
Thank you. Thank you, Arun. Thank you, Rajiv. Thank you,
Thank you,
Sandeep.
sir. Thank you, sir. Good evening, sir. Thank you.
Technical team, with this we can conclude the session. Please close it.
Active.
Yes, sir. Okay, sir. Yes, sir.
We have finished our meeting. Can close it.
Can we close the room, sir?
Yes.
Okay, thank you, sir.